Good morning students, I am Anuja S. Varghese, lecturer of Emmanuel Arasa College of Pharmacy. Today we are going to discuss about the topic of pediatric prescribing. Then first one, introduction. Children, particularly neonatal, differ from adult in their response to the drugs. Special care is needed in the neonatal period and this should always be calculated with care. Major difference in drug absorption ability exists between neonates and adults based on the route of administration. The use of intramuscular injections in the neonates is limited due to lower muscle mass, lower subcutaneous fat and higher proportions of water. Fact is, infusing the distributions of drugs such as a protein binding and compartmentalizations of body water change continuously during the first year of the life. This as a body composition changes with the development, the relativity volume into which a drug is distributed also changes. In general, protein binding of drug is lower in the newborns. As a result of this free drug concentration increasing which result in a toxicity. Children are not small adult. Rapid changes in size, body compositions and organ function that occurs during the first year of life. Adolescence studies reveal complexity in drug metabolisms and difference in drug metabolism between the sexes. An information gap currently exists regarding the developmental and generic acceptance, that is the possible role of polymerism of liver enzymes regulations and its potential effect on pediatric drug therapy. Then, what may be the cases? The growth in liver size does not seem to play a role. The growth in liver size does not seem to play a role. Possibly neuroendocrine determinants of growth and malnutrition may in part be responsible for the observed developmental difference in the activities of certain drug metabolism enzymes. Pharmacokinetics and pharmacodynamics are very different in children and adults. PK and PD has a relationship in most drugs in both children and adults. What do you mean by pharmacokinetics? There is high importance of clinical pharmacokinetics in optimization of drug therapy. Drugs that are safe and effective in one group of pediatric patients may be ineffective or toxic in another. Drugs that are safe and effective in one group of pediatric patients may be ineffective or toxic in other. So, an understanding of variability in drug dispositions is essential if children are to receive rational and appropriate drug therapy. Pharmacokinetics means, then repeated, there is high importance of clinical pharmacokinetics in optimization of drug therapy. Drugs that are safe and effective in one group of pediatric patients may be ineffective or toxic in another. So, an understanding of variability in drugs deposition is external if children are to receive rational and appropriate drug therapy. Absorptions. Two factors affecting the absorption of drugs from the gastrointestinal tract are pH dependent, passive diffusions, and gastric emptying time. Other is gastrointestinal tract enzyme activity. pH means evaluated pH more than inefficient range from 6 to 8. Gastric emptying infant neonates prolonged gastric emptying time but lower pediatric movement than older children and adult. Children and adult. Pharmacokinetics means ADR. What does to the ADR? Absorption, distribution, metabolism and elimination. Absorption. In prenatal infant, higher serum concentration of acid-labile drugs such as penicillin, amoxicillin and naphthalene, and lower serum concentration of weak acids such as phenobarbital can be explained by higher gastric acid. Gastrointestinal enzyme activities, it is lower in the newborn than in the adult. Activities of amylase and lipase, beta glucocarenes and glutathione peroxide enzymes are low in the infants upon the 4 months of age. Neonates also have a low concentration of bile acids and lipase, which may decrease the absorptions of lipid soluble drugs. Absorption from intramuscular route, less pediatrical absorption in infant. Example like diazepam, rapid absorption, and phenobarbital and pure absorptions. Less pediatrical absorption in infant. Example diazepam, rapid absorption, phenobarbital, pure absorptions. Absorption from skin. Percutaneous absorptions may be increased in a neonate because of the underdeveloped epidermal barrier and increased skin hydrations. Statinium corneum. Absorption from retail route. The retail route of administration can be useful in infants or children who are unable to take oral medication. The mechanism of retail route absorption is probably similar to that of the upper part of the gastrointestinal tract. Deposited difference in pH, surface area, and fluid content. The mechanism of retail route absorption is probably similar to that of the upper part of the gastrointestinal tract. Deposited difference in pH, surface area of fluid content. Then as distribution. Drug distribution is determined by physiochemical properties of the drug. It is a pKa, molecular weight, partition coefficient, etc. Psychologically factors specific to the patients. Drug distribution is determined by the physiochemical properties of the drug. Its pKa, molecular weight, partition coefficient. So variable acceptance the physiologically functions such as a total body water, plasma protein binding of drug, volume of distribution. Total body water, plasma protein binding of drug, volume of distributions. The total body water 94% in the features, 85% in permanent infants, 78% in a full term infant and 60% in an adult. Protein binding less in a newborn and infancy. Then volume of distribution, the decreasing in plasma protein binding of drugs can increase in their abundant volume of distributions. Total body water 94% in liters, 85 features in permanent infants, and 78% full term infants, and 60% in adult. The protein binding less in newborn and infants. Volume of distribution. The decreasing in plasma protein binding of drugs can increase in their permanent volume of the distributions. Next topic is metabolism. Drug metabolism is substantially slower in infant compared with older children and adult. Less malnutrition of various pathways of metabolism within infinity. Example, sulfatonin pathway is well developed, but the glucotinine pathway is undeveloped in sufficiency. The cases of the trachonic chloramiphenicol-induced gray baby syndrome in newborn insufficient is a decreased metabolism of chloramiphenicol by a glycemical transference to the inactive glycogen metabolite. Because of decreased metabolism, dose of such drugs as theophylline, phenobarbital, phenytoin, and diazepam should be decreased in premature infants. Particular microsomal enzymes such as CYP2C9, CYP2C19, CYP1A2 are variant in their functions. Then last one, elimination. The process of glomerular filtration, tuber secretions and tuber reabsorption determine the efficiency of renal excretions. This process may take several weeks of 1 year after birth of develop fully. Glomerular filtration rate is about 2 to 4 ml per minute, 1.73 meters square in term infinite. In infinite, if possible, then avoid chloramiphenicol and aminoglycoside because their metabolites are accumulated due to immunological functions of kidney. Especially chloramiphenicol metabolites are highly accumulated due to less developed glucuronate pathway which convert the chloromiphenicol in highly water-soluble motility. Especially chloramiphenicol metabolites are highly accumulated due to less developed chloromiphenicol pathway which convert the chloromiphenicol in highly water-soluble motility. Child-friendly drugs, factors that can increase the level of compliance and therefore improve the therapeutic outcome of medications in the pediatric populations included dosing flexibility and dose administration. Most influential products beginning used for children are not especially designed for the pediatric patients. The volume of intraocular medications are dosed on the basis of that for the adult eye, which can cause us discomfortable in the child. Palatability and appropriate dosage forms of oral medications are also important that up to 15% of children on oral steroids refuse to take their medicines because of the burdens associated with this compound. Children uniqueness. Many physiological differences between children and adults may result in age-related changes in pharmacokinetics and pharmacodynamics. Factors such as gastric pH and emptying time, intestinal transmitter time, immunity of secretions, and activity of bile and pancreatic fluid, among other factors, determine the oral bioavailability of pediatric and adult populations. Anatomical, physiological, and biological characteristics in children also affect the bioavailability of other route of administration. The next, drug therapy in pediatric. Dose calculation, choice of drug forms, dosage forms, disease condition, adverse reactions, and counseling. Drug therapy in pediatric, dose calculations, choice of dosage form, then diseases, conditions, adverse reactions, and one counseling. Then dosage calculation, Height and weight growth are rapidly changing factors in childhood, which also influence significantly some peak kinetic parameters. So, these factors should be considered during therapy. So, this calculation is needed. This should be obtained from pediatric book for children. For example, in India, IAP drug formulary is reliable source of pediatric practice and their important drugs. For many years, pediatric dose calculation used pediatric formulas such as the Fenn's rules, Ames rules, and Clark rules. These formulas are based on their weight of the children in pounds or on the age of the children in month and the normal adult dose of specific drugs. Then dosage for children up to 1 to 2 years Fenn formula age in month in adult dose by 150. For children below 12 years Ames formula age in years in adult dose by age plus 12. If weight is the pound, Clark formula weight in pound in adult dose divided by 150. For children above 12 years, Nailing formula age in years in adult dose divided by 20 based on the body surface area. Surface area is equal to height in the centimeter into weight in the half divided by uh, 3 no, child dose is equal to surface area of the child in a meter into adult dose divided by 1.73. Choose of dosage form oral route and parenteral route. Oral route means tablet or less constantly liquid paraffin are easily to administered in accurate dose and to form indescribable dose by dilutions. Parenteral route site of access safety from fluid overload avoid about excipients. Dose treatment section factors to be considered when selecting a drug regimen or route of administration for a pediatric patient care. Age, weight, surface area, access the appropriate dose, access the most appropriate interval, access the route administration, consider the exporter response and monitoring parameters, interactions and legal consideration. Legal consideration. Third one, disease conditions. Liver disease. Drugs with a high hepatic extraction ratio less than 0.7 such as drugs including morphine, morphine, lidocaine and propanol. Clearance of these drugs is affected by hepatic blood flow. A decreased hepatic blood flow in the presence of such diseases state are cirrhosis and congestive heart failure is expected to decrease the clearance of drug with high extraction ratio. Theophylline clearance may decrease by 45% in child with acute viral hepatitis because of a lack of specific data on dosage adjustment in liver diseases. Drug therapy should be monitored closely in pediatric patients to avoid potential toxicity from excessive doses. Renal disease. Renal failure decreases the dosage requirement of drug eliminated by the kidney once again because of limited study dosage adjustment in pediatric patients are based largely on data obtained in adult. Serum drug concentration should be monitored from drugs with narrow therapeutic index and eliminated vacuumly to optimize therapy in pediatric patients with renal deficiency. For drugs with wide therapeutic range, example penicillin and cephalosporin dosage adjustment may be necessary only in moderated to severe renal failure. Renal clearance or rate of eliminations is directly proportional to the glomerular filtration rate as measured by endogenous renal creatinine. certain clearance, that is a renal diseases. Said fibrosis, the drug therapy is pediatric patients which status fibrosis has been received for unknown reasons. These patients require increased rest of certain drugs. Studies have reported a higher clearance of such drugs as gentamicin, torbensin, nitamicin, amikacin, dioclorosin, and chlorocinin, acylocinin, piperacins, and theophylline. There is a variant in hepatic metabolism activity or the phenotypic distributions of metabolic polymorphisms may explain so pharmacokinetic difference in the congestive failures. For adverse drug reactions, adverse drug reaction therapy mechanism is not clear in adverse effect on many drugs in child, but it may be due to inert p-kinetic parameters and some medication error. Some well-known adverse effect: triacycline, teeth bone colorization, corticosteroid growth suppressions in pre-tubal child, paradoxical hyperactivity in child with a phenobarbital treatment, aspirin treatment, Reye syndromes. Fifth one, counseling adherence and concurrence. Patients are often responsible for the administration of medicines to their child and other for conditions and adherence of both the patients with the prescriber. Non-adherence may be caused by several factors such as the patient's resistance to taking the medicines, completed dosage regimes, misunderstanding of instruction, and apparent ineffective or side effective of treatment. Several general principles should be considered to attempt to improve adherence. Attention should be given to the formulation, taste, appearance, and ease of administrations of treatment. The regimen should be simple and tolerant to the child wake. Many health professionals often counsel the parents only, rather than involving the child in the counseling process. Where possible, treatment goals should be set in the collaborations with the child. Studies have shown that parents consider the 8 to 10 years age group the most appropriate at which start including the child in the counseling process. Pharmacist role, education training. All pharmacists should be receiving classrooms, lectures, and clinical experience in the pediatric pharmacy. This interested and pediatric practitioners should complete additional course and practical training in the children and hospital clinic. Postgraduate recently training in pediatric pharmacy is highly recommended for additional practice and management experience to future enhance clinical skill, especially in the area of pediatric disease management. Establishing in a pediatric clinic. The principle of establishing a clinical practice in pediatric pharmacy are similar to thus the of developing pharmacy practice in specialty. The process should be initial by identifying the type of pediatric patients beginning cased from other institutions. General pediatric patients seen for elements such as gastrointestinal, respiratory, and injections. Thank you, student.